Are you guys ready?
Yes.
Okay. I'd like to welcome everyone today to our the Georgian Fahey Center for Healthcare Innovation's monthly Lunchtime Learning Series. I'd like to welcome everyone in the room, but also those of us who are joining us via webinar. And I guess one of the first questions I have just for our tech people is, people on the webinar, can you hear me? If you cannot hear my voice, wait a minute, that doesn't make any sense. If you can hear, if you can just type in the chat, yes, I can hear, that would be wonderful, because we just want to make sure that everyone can hear us as well. So my name is Carolyn Shimon, and I'm really excited about today's talk because we have the privilege of having our patient and public collaborative partnership members here to chat to you today. The Georgian Fahey Center for Healthcare Innovation is part of the strategy for patient-oriented research. And we realized, so just to give you a little bit of background about the group very quickly, is in 2017, we went out and we recruited, we went out and talked to diverse people across Manitoba to make sure that we had equal representation on all of our strategic advisory boards, our executive council, our scientific advisory council, and a bunch of other groups to make sure that we had people with lived experience sharing their knowledge and insight and experience. And that's how this wonderful group came together that we get to chat to today. At the time we had nearly a dozen inspiring and insightful, passionate people across the province to help us begin to co-develop really authentic engagement strategies and policies and resources and tools and really help inform some of the research that's being done here at the center. So we come together on a bi-monthly basis, and everyone brings such a wealth of experiential knowledge to the table, discussing priority areas in health research, as well as healthcare systems and things that mean the most to them and their families. So, and of course that we bring together some food and some fun and some laughter as well. So I want to begin. I have the privilege to introduce each of our members. We have 4 members here today. I'll kind of go down the table so everyone can get to know people. We first have Angela Tessier, whose background is in science, and she immigrated to Canada from Ireland, and she has a master's in biochemistry, and she worked for many years as a workplace educator working in various industries. She also taught internationally trained professionals as an ESL instructor, and she's currently at Red River College as an assessment program analyst, where she develops assessments and then implements customized solutions to enable students to succeed in their courses. And in her spare time, I feel like I'm doing a nice advertisement, and in her spare time, loves to bike, read, travel, and debate politics. Next.
Tomorrow is advertising.
Next, we have Thomas Beaudry. Thomas comes from Winnipeg, Manitoba, and is a proud Indigenous man, a proud father of 3 young men and a young woman, and a misham of 2 boys. He's a graduate of the Center for Indigenous Environmental Resources with a certificate in environmental protection, with a focus on environmental related issues concerning Indigenous peoples and communities. And Thomas is currently employed with the Province of Manitoba Department of Sustainable Development as an Engagement and Reconciliation Community Coordinator. Then we have Empo, Jens, and Empo works for Arxium, a medical device company. She's also an entrepreneur developing an innovative mobile health platform. She's involved in the community as a board member for Grace Hospital Foundation, as well as a committee member for the Immigrant and Refugee Community Organization of Manitoba. Empo co-chairs our wonderful collaborative partnership and is part of our executive council, as well as Thomas. And Empo earned a master's degree in computer engineering from the University of Manitoba, and she's a professional engineer registered with Engineers Geoscientists Manitoba. And then our wonderful, last but not least, is Lori Dita, She has been a healthcare aide for 34 years at actually Margaret St. Boniface. She enjoys caring for people, takes great pride in getting involved with organizations that can make a difference. She describes herself as a pit bull when it comes to trying to make a difference if she thinks something is not right. So Lori is the president of her local union, the MTU, and was formerly a director of ASDA for 9 years before they amalgamated with the Assiniboine Credit Union. She's an Indigenous woman who takes great pride in her culture. So I'd like to open things up with our presentation. First, Thomas and Anto. Just a little bit to give you some background. Oh, and before we begin, actually, Angela is going to do the traditional territorial acknowledgement. Oh.
Okay, so the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and many peoples, and on the homeland of the Métis Nation. We respect the treaties that were made in these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration.
So Thomas and
Okay. Thank you, Karen, for the introduction. So our presentation, we're just going to give you an overview of how we first started as an advisory group and then us to involve collaborative partnership for engagement. So starting community, to us, community is a cycle. We are all equals. We build relationships. Nobody is better than another. We respect ourselves first, and then our community, and then our connection.
The circle is a part of a whole. It's not an isolation, because it symbolizes people, community, different walks of life, and diversity of all. From healthcare to aid to the workers and the patient and caregivers. It is not motionless. It has no beginning or an end. It always involves and is inclusive of all beings.
So what were motivations for developing a collaborative partnership? The first motivation was to advocate by hearing patient voices and creating opportunities for all voices to be heard.
It is a diversity of perspectives that come together as a voice.
So having been a patient receiving both acute care and outpatient settings, I believe I can speak on behalf of other patients, my experience of what work and do.
I have an interest in learning about the healthcare system in Manitoba, and as an Indigenous person with a strong interest in societal, systemic issues as a whole, and specifically the impacts of colonization on Indigenous peoples. I can assist by being a bridge between healthcare researchers and the Indigenous peoples.
For myself, I hope to engage and get feedback from the immigrant and community on the challenges they face in accessing healthcare in Manitoba.
As an advocate, I can offer my thoughts and ideas as well as my experiences as an Indigenous person with the difficulty of finding and obtaining the right type of health care for myself, family, and the community as a whole.
Our second motivation was to innovate. Be innovative by being flexible.
It's taking the time to build relationships.
And feeling comfortable and being listened to.
It is co-creating guidelines and resonate with each other to outline how we want the relationship to be.
We don't always agree, but we respect that we see.
Some of our successes and outcomes of our patient and grievance collaborative partnership are developed in a handout. So if you want something for people that are here, we can get it for them.
Our last motivation was to guide. We like to guide by taking the time to build relationships.
And it is non-judgmental.
By building ourselves.
It is communicating in different ways.
I would like to guide by asking questions.
It is comfortable being uncomfortable with one another.
I would also like to help by address bias.
Our partnership influenced changing terms of reference to our guiding principles of emotional, physical, and cultural safety and it is a way to keep our family safe when presenting to others. These will be listed also in the handout if you want to look at them.
These guiding principles were developed from our safe spaces, and we asked different questions. What does emotional, physical, and cultural safety do, look like to you, and feel like to you?
With these three small questions and these three small areas, this created a very close family, collaborative or partnership engagement. We will start with emotional safety.
Emotional safety is respect.
It is creating it is creating a non-judgmental space for everyone to express themselves and an opportunity for all voices to be included and heard.
It's okay to ask questions, observing, learning from one another, and not just using your eyes and ears for.
It is having self-awareness of one's own feelings and environment in order to keep oneself safe, others also.
So it is about being honest and being honest.
It is for us to support each other and create space of empathy and compassion.
It's recognizing that it takes courage to share one's story.
It's about respectful humor and laughter, to lighten the topic and create healing with that laughter.
Next is physical safety. Physical safety being our way of each other's comfort, adult and honest.
Culture safety is also a safe space to communicate across cultures and welcoming and acknowledging cultural contribution. To us, cultural differences is how we express ourselves, and verbally and non-verbally. As example, in some cultures, not making eye contact is a sign of respect and is misunderstood outside of them.
So we have demonstrated that you cannot have a collaborative partnership engagement without asking these tough questions and writing on them.
Culture safety. So, and we need to understand that we are in this circle together, and as you are too, you're in our circle. Any questions or we hope?
Or maybe we start with a few questions that we'll chat about as a panel. Maybe Angela, we'll start with you. From your perspective, what would you say are some of the big differences between an advisory group and a partnership?
First of all, I think we specifically as a group made a decision to switch from the name. Originally, our name was Patient Engagement Advisory Group to Collaborative Partnership. And that overall reflects the overall strategy, for want of a better word, in terms of how we see patient engagement working. It's to us, an advisory group was very much a sense of being hands-off. We were a sense of advising, versus a partnership is much more collaborative, much more hands-on involvement, much more a sense of walking the journey with researchers and patients both engaged in the actual process. And because there's a sense of it being an advisory group, it's essential to listen from the very, very beginning. It's not something, and we saw this evolution ourselves in terms of a group. It was very, very necessary to put the time in right from the beginning and to really start to walk the journey together in terms of getting to know people, taking the time to build those relationships, taking the time to build the level of understanding. And then the last part, which, as you know, I'm also a researcher myself, and it's probably the most difficult, but when we think on a much more societal sort of, what I like to call 30,000-foot level, being vulnerable. We're not a society that encourages asking of questions, being vulnerable, being open to new ideas, and setting up within your partnership the sense of it being okay to ask questions. And that fundamentally comes from a foundation, a bedrock of trust and understanding. And that
Thomas, how do you think how does the partnership ensure that the guiding principle?
Oh, as we say so. Just kidding. Just kidding. Well, I think our partnership is that when we first started, we were trying to get away from that terms of reference, which makes it sound very regimental, very government driven. We wanted to get it where it becomes more from the patient and or the caregiver of how we're going to go forward together. So it's going to guide us, and when we are no longer part of it, it'll also help guide the patient. I think our guiding principles is all about safety and respect, and how to be humble at the same time. Because if we're not using some of these, well, as an Indigenous person, I use a lot of R7 teaching, humility, love. In our group, we kind of look at that. If you look at our circle, it's all about that, and it's about loving one another with that respect. Because I think the key to having those guiding principles, and once in a while looking at Angela, Cole, and Laurie, we respect that we are different, and it's okay to be different. Because if all of us were the same, it would be a pretty boring world. So these guiding principles is a way to show that it's okay. You're okay to be different. It's okay to ask those kind of questions. It's okay to say that I don't know. But if you come to our group, ask us. There's many of us. Like one elder has told me, the good thing about another way of knowing is that we don't always have to be the one with the answer, because everybody will have it. So that's just another way of looking at how we're.
Hello. What advice would you give to researchers who are interested in engaging patients in partnership? Where should they start?
I think the best thing that researchers is just be open and listen to patients, and also try to build relationship first before they kind of discuss what they need. Because I think having that open relationship gonna create a safe space for the patient to be open and be able to share their stories and go deeper than when they and tell the researcher what they think the issues are. Because we all need to open and talk to the researcher issues that they wouldn't normally talk to a stranger about. So I think the relationship and creating that bond and have safety and emotional safety. Share those deep issues.
Lori, just from your perspective, what kind of advice would you give someone who might be interested in getting involved? A patient, a partner, a caregiver. Don't be afraid to come and sit, but I'm comfortable as I am. I'm not one that brings never of anything. It is able over there.
To make a change, if you get involved, don't get involved, then there's no reason to complain about it. Getting involved, makes you a better person. You learn, you grow. I grow with every meeting I have. When I come to Chief, get involved. That's great.
Did we want to, are there questions from the audience? Oh, Carly's got a
Hi
question.
everyone, I'm Carly. I work with Carolyn and Trish in the knowledge translation platform. And I actually just wanted to build on what you just said, Lori. I love you guys having your guiding written down, because I think it's so easy for us in health research and any industry really to know, like we have our own acronyms and lexicon and spaces and things that are so normalized to us that it's easy to forget how uncomfortable it can be to someone else, right? And so I know you guys meet every month and you have meetings and you guys are all very close, but then suddenly we throw in, you guys come in at noon in front of all these people and talk, right? And so I love you guys have written down that ongoing concern and just like making space for how do we keep ourselves safe when we're asked to do these extra things and asked to put in. So I want to comment that I love that that's in there. And the no cell phones. Written down somewhere. But yeah, no, it's just such a fascinating because it is so easy to look at that as a health researcher and be like, well, I don't know why that's even a concern, right? And forget that for somebody else, it very well can be. In the same way that I think sometimes I know health researchers will come to your guys' evening meetings and they're terrified, right? Because they know you guys are going to ask hard questions and they know, right? So for them, that's them getting a comfort zone.
Yes, that's what we are hoping to do.
Terror, it's good.
Well, to build on that, one of the biggest things researchers or doctors meet with, talk at our level. We all don't talk doctor and we all don't talk research. And if you're going to be working with the patient or the caregiver, talk in a language that they understand. Good to use your, what grandpa used to always say, your $3 words when you're with your $3 people. So you don't have to use it with us. Be plain, direct, and open. The reason I say that is my partner almost died of septic from a kidney stone. And I was listening to the doctor, and we're talking to me, and I'm sitting right there in the room, and well, we don't know how much time. I'm not picking up, but I kind of understood some of the terminology that we're using. But, excuse me, can you tell me what is happening here? They kept on talking around me. So I finally just said, okay, that's enough. How much time does she have? And they said, oh, they didn't know how to talk to me because I was very direct. The reason being is in our culture, we have to get her kids there and her family members there before she passes because she'll give her last breath to us. And that last breath is from our generation before. And at each of our generations, pass it forward. Nobody can be there with her. It is broken. So we need that honesty. We're not afraid of it, but it's better to be honest with it. But if you're not honest with us, then we become afraid. And we don't need that here. Neither do you as a researcher. It's working. So it's better to be open.
Are there any other questions for the group?
Don't be afraid.
I would like to add to what Thomas has said, and I think from both perspectives, whether it's as a patient involved in research or whether it's as a researcher, just ultimately remember who you are serving. That's very, very important. And the other part is to also realize conflict is okay.
Yes.
Conflict comes out of trust, and conflict allows us to ask the hard questions, which in fact moves us to the much higher level and ultimately can actually make for better research. And again, who are you serving? So that's why I always encourage people to remember who you are serving, to listen, and the sense of being open to ideas. I as a researcher, I know the issue of grant proposals, and we've got to fit it into this particular box. We've got to be able to, but we've got to think outside of that box and how can we maybe the patients have the better research idea, but this isn't going to get funded. So part of it is thinking, who are we being of service to?
So I know there's lots of people here from Gaia and different organizations, and I don't know if everyone in the room necessarily knows like how often you guys meet or the process of engaging you. If somebody had a research project that they wanted to engage you in, maybe you guys could walk through what that looks like on a logistic platform. Yeah.
Well, maybe if you come here.
All the way
Come
here.
here. Come here.
Oh, I know what you're gonna do.
This is a handshake.
It's like, hello. This is how we do it.
But they don't know where you are to shake hands.
Well, with that, when we meet in the building here at 450.
470.
473 McDermott, 3rd floor. The easiest way to get hold of us would be through Carolyn.
Yeah.
Or or Trish, way in the back, she's hiding on us. And if you know them, and if you don't, I know there will be some contact information that will be shared. One of our goals, we've been talking about it since we've been meeting, is that we want to actually meet with the researchers. Because sometimes the researchers doesn't know where to go or who to talk to or who to engage. Well, we tell everybody that meet with us, we don't want to necessarily be part of your research team, but we'll help you find somebody that could be available. Because it would be unfair for us to try to help all the researchers that are out here trying to do projects, the 8 of us. As you can see, and I'm the only male within this panel, a great balance, because I think it's important about balance. So the easiest way is to reach out to Carolyn and Trish to get hold of us, and we would love for you to come and talk and be able to help. We would love to even conference call. We would love to even see a letter from you to see if we can help, because the more we engage, the more we are going to go forward. And then you're not forgetting anybody. Because a lot of time, from an Indigenous perspective, it's about trust. And like one elder told me, we are research to death, but we never know the outcome. What he meant by that, people fly into the community, research us without really engaging and talking to us, fly away, mail us a report, don't understand what that report is. You know, or we have a trust with hospitals and doctors due to our past with residential schools where our children were experimented on for tuberculosis. Find a cure for tuberculosis without a paid parent consent, or without the parents even knowing that, or even without the parent knowing that these children had died from those pathogens that were injected. So we have that mistrust, but now it's about building that trust. And this is how we build a trust. It doesn't matter even if we're Indigenous, non-Indigenous, just building a trust that we go forward together. Like Angela said, I'd say my biggest thing is it's time to be comfortable being uncomfortable when collaborating. That's such a hard thing because when you're uncomfortable, you don't want to engage. But that's okay. Start being uncomfortable and accept it as a norm, because people's perspective is always different. And that's good, because there's more than one path to get to that end. Yes, it might be for your paper, it might be for your research, but you might not have seen something that they've seen. Same thing, we might not be able to see what you're really trying to do. And that's okay. So we might, this way we can do it together and we'll go forward. I know I talk a lot, sorry.
And one way, because we were mentioning if you want to engage the group, is we have an email address. It's phipartners@umanitoba.ca. And what you can do is send us an email, and usually what we'll ask you is just to have a very lay summary of the work you're doing. And then it goes to the group, a very democratic, we go to the group and we ask, is this something of interest? Would we like to, and then the group will decide yes. And then oftentimes the group will decide if yes, for you to come in and have a conversation with them. And of course, what Thomas was saying is even just suggesting ways to engage or people you might want to go and talk to. And along the entire spectrum of the research process, helping to kind of help you guide you a little bit. Trish, are there any questions from the webinar people? Oh, Catherine.
So this is for you too, Carolyn. There's 12 persons in the group.
We are down to 8, but I think we have 8 right now, but we're recruiting soon.
We discussed that at one of our meetings, recruitment and what we think we're short of. We came up with a pretty good list. We're missing youth, men and women, missing elders, men and women, and we're missing more newcomers, universal. Because I think it's important that we work with all of these. And we can't speak as a well, maybe I'm getting there. But I mean, or I can't speak as a youth anymore. And then their concerns. And we would love to help their voices, because youth too are going to be our future. And who knows, maybe it might influence them to become a researcher or become a doctor, being part of the same, because I never knew how by talking to a researcher or bureaucracy.
So you guys sort of answer the question of them on you're aiming for diversity, and I look at the word you mean you're extremely well educated, well spoken. I'm sorry, how do you handle inviting other group members in that may be intimidated by what you're presenting here?
Well, I just finished the academic science health care
Health sciences leadership course.
leadership program. I asked to participate in it. I'm the only non-doctor, non-researcher in the process. I went there, oh no, I'm not going to be intimidated by them. I'm going in there with my heart and my mind and another way. So I wrote a paper. It's called Another Way of Knowing Two-Eyed Seeing. Choosing Western science, one eye, and using the best of theirs and indigenous knowledge of science. But not looking through one eye at a time, but looking through both eyes so that we can walk together and heal and do these. So when it says education-wise, there's graduating basics twice common. No, I'm just kidding. But I mean, education-wise is one of the things that I say we don't. Because our way of knowing as Indigenous people cannot be measured within a classroom. We're connected to that. But our Indigenous science is 10,000 years old. For Western science, maybe 300 years old. It became universally accepted as because of colonization. That third way is the only way because it's written. Well, I always use this comparative. Well, you only could remember in Western science if it's written, you read it, and everything like that. While our science is oral, passed down. And we have to remember what they're talking about. So whose mind is actually more open? As one elder in the Kanesatake Nation, they take young people who talk about their whole history in their language, their proper breaks, and they have to present it to the Council of Elders when they get to a certain age in their language, exact break. They make one mistake, one pause in the wrong spot, they stop the conversation and have to go back and relearn it. Because it's like I say, 4,000 years of history and 4 days of sleep. So they need to remember it orally. So think about the mindset of what you need to remember. So that's where my paper went with two-eyed seeing, or another way of knowing is that it doesn't mean one is greater than the other, but it's how we do it together and how we're going to go forward together. One is not better than the other; they complement. And so, how do we do that? Being open, looking at our own internal biases, looking at our own prejudices before we take that step forward. Because if I look at you and say, oh, I'm not going to deal with you, you're part of the white people who imposed my grandparents residential school. If I took that and kept it, I wouldn't be seen. So I'm trying to take those negatives and trying to find a way of how we can heal together. Because it is a healing together. It isn't about just speaking together. So I guess that's just a different way of looking at it. I don't know if that's. I know in our discussions in our group, that's how we are. We look at everybody and says, liar, from her or that's one. And then we have people right from here who are going crazy. But we come together and work together. We respect everything that she has done for you. We respect everything she has done for you. And they respect everything. But when we work together, sometimes I just sit back. You know, they go ahead and I'm not talking. But when they finally go and I say, they go, oh no. Because I add something to it that they've already discussed and they go, okay, but we're not doing it that way anymore. But I agree that sometimes it's just a perspective. And it's nice to say, yeah, no. But we, like when she was saying it's a democratic society, we don't look at it that way. We look at it as consensus. and we don't really vote on it. I might not want that presentation, but it might be of interest to all the other this group. So why should the one voice be in control?
I think we have a related question from online.
Oh, right on.
It kind of goes with that. Question is, in your opinion, who would contribute better, a patient representative from an association or group, or a patient as an individual?
Patient as an individual.
Yeah.
I would think, or an organization or group. They have the lived experience, they're going through it. And they can tell you how they feel.
I agree with that. Or the caregiver. We all, a lot of times in research is forget about the caregiver. We're living their pain.
What what you, I work as an healthcare aide. I teach people. I need direction from, I don't know how many people. That's WRHA, yes, my management, senior management. I'm the one that's caring for the person. And they don't even have a vote. They don't even, they're not even asked if they would like it done this way. So they're just told what we're doing. I don't do that. I go and do what I ask. And so probably not listening to my superiors, but I ask questions. Thank you.
I've enjoyed listening, so thank you so much. The aspect I really want to talk on is the issue of conflict when the person with experience or patient has a contrary opinion to the research, and the researcher is coming up with this huge knowledge, think if we go this way. So have you experienced such thing? Which one do you think should, how should that be managed, or should the person with a deep experience supersede in terms of how to resolve this?
I think these are always difficult situations, but it goes back to if it's a partnership established on trust, that's out of the trust, conflict will arise, and you can start to ask questions, but it takes time. Like there's a level of vulnerability that's needed. But I understand that from a researcher's perspective, the pull that's there is very, very difficult. But there's a need for people to communicate from both perspectives: the patient with the lived experience versus the researcher, and there needs to be an understanding in terms of a commitment. An understanding in terms of moving forward in terms of some sort of a resolution that will help in terms of moving the entire situation forward. It's very, very difficult. There are no tick boxes in this one. Unfortunately, there are no tick boxes in terms of this, but so often it's the experience of the patient that maybe it's some side effect of the medication or something that had not been thought of previously that actually is what needs to be dealt with. And so it's very, very difficult. Like there's no wrong answer. There's also no right answer either in terms of this. I think each situation is going to be very, very unique in terms of that. But sort of peeling back the layers, but ultimately, if you're walking the journey in partnership, that's how you're going to get a resolution in terms of.
I'd like to add to that because one of the biggest things is respect. Time. Like we understand researchers have a timeline, but us as patients, caregiver, we don't care about your time. Be honest. Reason being is that if you don't respect us, talk to us as human beings, we won't respect you back. So you have to develop that relationship. It's going to take time. It's going to take trust, and it will be reciprocated back. And when the conflict arises, well, if you develop that relationship, as Angela said, it can be resolved. And that's where that difficult conversation starts. And and one of the things, if you watch Angela speak, she spoke in a circle. Everything was in that circle. When we're in that circle, we're all equal. You might be the researcher, but you're still a human being first. We are a patient, but we're also we're a caregiver also. We're a student, we're also equal. There's nobody that is greater than us. If we start with that, we're all equal, we'll be able to start off with good respect.
Do you think, just following up on Alex's, do you think in having the guiding principles and having that conversation at the very beginning when we first formed, do you think that really helped you as far as if we have disagreement?
I think so, because we were supposed to have one meeting. It took 3 meetings for us to come to a working way. They expected us to do it in one, and we kind of went. And then I think they knew what kind of group that we developed. So I think that was the key, is that if we were going to participate, it had to be from us.
I also like to add that in as a thereby any goal worker to achieve the project, right? So if we have patient and then we find out, oh, you know what, maybe it's not how I thought this is going to end. I think it's okay to the project and try to do something that's going to be really a result at the end of it.
If say an organization wants to start their own patient engagement, building the zone, especially cultural safety, which we know we've talked about, is familiar to a lot of people about, and what would you recommend to a brand new group on how to build that culture? Or even emotional safety?
Well, I think when you're talking about cultural safety, it isn't just about Indigenous culture. Everybody has their own culture. Every group has their own culture, dynamics. It's what you feel. And that's how we came about it, was how we feel. I use my feather as a way to keep myself calm. And part of my spirit thing has to do with it. So it grounds me. Doesn't necessarily have to work with a group. And you have to develop that. So whenever a new group wants to start, talk about your own culture. It's your culture of the group. It isn't the culture of the business. It isn't the culture of the Irish. It isn't just the culture of a woman. We have to create that, and we look at it as humans. And we got back to the basics. And because we forgot about that, as an Indigenous person, we were actually patriarchal society. And that changed with colonization. Patriarchal from him, we see. It's not true. If it wasn't for the woman, then we wouldn't be here. And we get back to the basics. That's what we say. The basics is creator, myself, and extended program. And how did I get there? Who do I have to be there for? So when you create that new group, when you create your own culture, it's the culture of the group, not the culture of yeah.
And I would just use it going to take.
It took this time. Yeah.
That's the key piece into this is in terms of building relationships and building understanding. So yeah, so when we get we have 1 month to write a grant, you gotta have a patient engagement piece in it. We're not going to participate because it's not going to happen.
Right.
It's not going to be effective.
And I was thinking when we had the safety conversation, remember our first meeting, what does it look like to you? What does it feel like to you? What does it mean to you? I think it was the group I think we had emotional, psychological, and physical, but I think the group even said, let's talk about cultural safety as well and what they mean, and had really good conversations around those experiences.
Because the culture wasn't part of our group when it was first initiated. We wanted to include that. And I think so, and I think that was a hard thing because we did look at Indigenous. But that's not what it is. I make sure that's not what it is. I'm a voice of the Indigenous people in that group, but it's not our group as Indigenous. I was going to do that. I would work with the Indigenous groups that are out there, but I think we need to be that voice internally, so we're always aware of what our surroundings are. And as an Indigenous person, I have to be aware of what everybody else's concerns and culture is. It's two-way dialogue. There's reciprocation, and that's the key is reciprocation and respect and trust, being humble. Well, that's hard for me, but being humble. Kidding. And in our group, we do a lot of laughing. Because laughing is part of healing, and we understand it. There's some things that come into this group that are very heavy. They know what I've gone through in the last week, personally, but I'm here because it grounds me. It grounds me because I know that they don't judge me for what is happening. So, and they can come in with the same face. We won't judge them. Oh, we hug them. No, we do. We did. But we did.
Well, and I think that's what's really interesting about this group that you would probably want to build on, Jennifer, because it's a group that's not specific to one thing, right? This isn't an arthritis advisory group. This isn't an Indigenous advisory group. Even especially if you bring youth in, there's so many youth advisory groups. This would be, it gets a bit to the question online of, is it people from one group or people as individuals? And you guys are very clearly a group made up of individuals that fit into lots of different groups, of which already have specific advisory groups all around the world. So that would be something that PHP would probably do as well, where it would be a broad band of individuals.
Well, because it brings more knowledge, it brings more emotion, it brings more connectivity. As everybody knows, the world is small. I think it's so big that it's small. And we are all related. No matter what anybody says, we are all related. No matter the skin color, no matter of nationality, no matter male or female, we're related. We live on this earth. We're all on it together. If you look at that one earth, but what I mean by circle, that's how you look at it as a 2D. It's actually an orb. And our teachings about circle means only one part of your orb. It's like a library. Pull it out, put it down, and talk about medicine. It's a flat thing. That's only 4 things there. But if we want something else to add to that, we go into that orb and put it down there and do that. So it's still, whatever impact that we do to that orb or to that circle impacts us. So when it comes to research, whatever you do in research, or whatever a doctor does, it impacts maybe that patient or whoever you're researching, impacts us too in the long term. Or yourself in the long term. Is it that important to have your name put on the internet or on the paper and say, look what I've done? Is that really why you're doing the research? Or is that really why you're doing the research to help healing? It's just to have your name, I'll say, in lights. Why are you really doing it? You have to really look at your own internal biases and why you are doing that. Because I think those internal biases and prejudices or your own ego is guiding you, and you're not really doing what is true. So we need to step back and always say, okay, why are we doing it?
Getting back to your question, what are we? say is there's several organizations that are out there, cultures, everybody, Canadian culture, there's German association. And there's a lot of people that are new to this country that would love to engage and tell you why they're in this country. I work in a facility that we get a lot of people from Congolese, Congo, and countries that were colonized by the French organization that I work for. And so to hear the war stories of why they're here and how much they love this country, they're welcome all from these people. So with the different culture. And then something that you want diversity.
Yes.
And that's actually how we found some of you got the word out about this group, I think, was that we contacted people.
I was gonna ask a question around one about, if you could speak to how the group formed and share around that. And the reason I asked is because we're, in the establishment of advisory council for Facebook, do we put out a call for applications, or do we reach out to our community that we know? And never quite sure which is the right way to go. I guess it depends on what you work, but you could share how you can.
There's no wrong answer. I got involved with this organization. I'm the third term serving member with what we're called Community Health Advisory Councils now Innovate. And I saw the advertisement on a newspaper, a community newspaper about 12 years ago. That's how I got involved. So I don't know how the other members of the committee got involved. So I don't think there's a right answer. And I think it's a sense of, and again, if you use our guiding principles around being open, asking questions, being establishing that trust, being open to ideas in terms of diversity, allowing people from diverse backgrounds to become engaged in any way, shape, or form, I think that will make for a very, very strong advisory group. And a very much rather than an advisory group, a partnership. So part of it is also looking in terms of the language. Is it an advisory group or is it a collaborative partnership? So that's also going to be very important in terms of your overall how you're going to approach it.
I'll just maybe, because I don't know exactly what the other person was going to do, so I thought we had a commission up front, and what they're going to be doing, so I think that very much joy interest will be.
You know, from an organization perspective, when we originally, I think we did a call out for 2 positions on our executive council, and we specifically wanted to get a lot of different partners. So we talked to community organizations, introduced ourselves as what we're looking at, and from there we got a lot of people referred you guys over to us, and then we had sit down, we had coffee with everyone, and started realizing how amazing everyone was, and so we thought, why don't we just have a bigger, larger group and bring all of this insight together versus having a few people on a group. So that's how so we did go through a process. I think you guys all did an application. Yeah, you did. and then
I followed the crowd. And
Yeah.
I sat down and said there was coffee and donuts, so I ended up going, no, just kidding. But I mean, it was basically like, there was an invite for a coffee.
I think he gave you us that big questions.
Yeah.
Just remember, remember that, not one question.
Yeah.
Being specific what you want.
And the great thing is now that we're thinking of expanding the group and having some more different voices, you guys are now part of you're gonna take a look at what we send out and also send it out to community members you think might be interested. So this way,
And I think it's all right to be afraid. Use that fear as something that'll guide you because we have to find a way to use this and use this at the same time. Not one guide the other. When that happens, you're not getting true balance. So it's all right. I'm afraid. Okay. My heart says, don't push one aside. Say, oh, it's the end. Also, that's your feelings. This, we're taught, don't trust that fear. It's just a fear, it'll go away. Well, I used to teach women self-defense. First thing I ask a woman is, you going down the back alley? What do you feel? I'm afraid. Why do you keep walking down that alley? In other words, it's all right to back up and go back out and kind of trust yourself first. In other words, if you don't trust yourself and you're just going, oh, you're really doing it.
I would just like to add to that, I'm going to think about Alex's question about, what happens when there's conflict. And I think it's important to lean into the uncomfortableness about it. And simply say, this is tough for me to discuss. As a researcher, I see this body of knowledge, but from a patient perspective, this is what I'm also seeing. And simply saying, it's tough for me to discuss this. And I have people on the committee know, I have what I call think aloud moments. Have we thought about? I'm just thinking out loud here. And that's what I do, is sort of saying, okay, have we thought about this? Is there a perceived conflict of interest here, et cetera, et cetera? And the other piece is, I'll also play devil's advocate moments, okay, where I will say, okay, all right, I can see now, how is this going to be seen? What is the perspective? So this is something that I very much grapple with, but it's going back again to that sense of trust and being vulnerable and being open to questions. So that's how it's different from a partnership versus question.
I know you guys have always been really good. There's been times where I've come to the group and said, I think I messed up. Like, I think I did something. And you guys are willing to let me know how I can.
Then we just go, again?
I think we've almost. We have one more question? Okay, what's it? Oh, Catherine?
Just, I want to know, who sets the agenda when you meet and who chairs? Do you have a rotating chair? Does that set agenda? Does that change every meeting?
Well,
how do you decide those things?
Very good question, because I'm the co-chair. She is the exiting co-chair. Our agendas are decided by us as a group, not by the chairs. We asked, is there anything we need? This is what we would like to talk about. And Trish and Carolyn send us out what we think or what they think is the agenda. And usually we change it. And so it's about more of what we want discussed in there. And maybe some of the stuff that we never discussed on our last meeting. Because our meetings, we do have an agenda, but it's not always. we don't always get to the end, because what we do get to it is taken care of in our own way. Because we always have these discussions. Why is that? Why is this? Or no, I don't agree with that. Okay, go ahead. I don't care. But in jest, but in hold on, let me think about that. Sometimes it can't answer. So it's the agendas are pretty open for us to decide what we do. The chairs, we try to keep them. They made me a note taker, so I really
And we have an online space.
Yes.
I guess, well, I'd like to thank everyone for coming today. An amazing job. And I guess if anyone has any additional questions, they can email our CHI partners email and the group can definitely, I can send it. Thank you so much.